Hello and welcome to Dragon Bytes, the paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Asim, one of the paediatric trainees here in Wales and one of the presenters for Dragon Bytes. This week we continue our two-part series on the biopsychosocial model. If you haven't had a chance yet to listen to last week's episode, it might be worth popping back and having a listen to that first. As a brief reminder, two of our Dragon Bytes hosts, Dr. Tom Cromarty and Dr. Celyn Kenny, were joined by Dr. Max Davie, a consultant community paediatrician based in London. They were discussing the biopsychosocial model and how we can apply it in our day-to-day practice. Anyway, let's get started.
I just think there's so many presentations that come in, even to the emergency department. You know, adolescents with syncope or pre-syncope or abdominal pain. Yeah, there's so much that comes in that, and that kind of environment is meant to be geared towards kind of quickly see them, get them sorted out. And sometimes I find that a challenge when there's, like you say, more than 6, when there's 20 to be seen and there's only you and there's 20 more after you've seen this one. And if you spend an hour there, then, you know, it's difficult. But actually, you know that in the long run, this is their one time when they've come to hospital, the first time, and it's going to be 6 months before they come again, and so much goes into what could happen to the family and what could happen to the family unit in that time.
Yeah, I mean, you don't have to spend an hour. It doesn't always take a long time. I think, in a way, so the two things about the time that I would say, one is it doesn't necessarily take as long as you might think once you get used to it. And once it's not, the thing that often takes time is when you've started off down the biomedical approach and you've kind of done some stuff and excluded some stuff, and then you make that transition to biopsychosocial, because the family are like, oh, so you don't think there's actually anything wrong, you think it's all in their head, because that's why you're making this shift to biopsychosocial. If, as part of your initial approach, you go, well, we always say, obviously, we're looking for pathology, but obviously thought, what's happening in your life and what's happening in your in your feelings and emotions are always important in all symptoms. And actually, it's not impossible that you could get other people, nursing colleagues and other colleagues to actually start getting some of this information as well. That's not beyond the realms of a possibility, is it? And just it doesn't have to be a kind of, oh, let's go in deep, let's go deep now, let's go deep into your psyches. It's basically, what's going on for you? Is there anything else going on for you that we think we could maybe change or kind of influence that might help? So with the colicky baby, the fact that mum's got depression, and they're in this horrible house that with noisy neighbours, and they're having all of these stresses. Of course, that's going to be important. It doesn't mean that you can solve it, but you're like, well, yeah, that needs that is a factor. That's important. That's not. It isn't just this baby and this kind of unknown biological process going on. It's just opening up a little bit of a box. And I think in emergency, it is very difficult. You can't actually resolve these things. But what my hope is, my kind of slightly naive hope, is that if everyone is a bit biopsychosocial, and actually GPs are pretty biopsychosocial, that if that seed has been planted, that there's more going on here, next time they go to their health visitor or their GP, if everyone is a bit biopsychosocial, then it will grow. It doesn't have to be just on one person to come up with this brilliant formulation or story for the family. It can happen across different professionals. The difficulty is, actually, there's quite a lot of people who just can't be bothered, who just want to get in and get out. The second thing to say about time, so I know I said two things about time. The second thing to say about time is, as a service as a whole, taking this approach, and again, this is something I'd love to be able to do an audit of, but I think it's so difficult to kind of capture, but you could potentially do it in a particular patient group, is, it seems obvious that you should be able to do fewer investigations. You should be able to keep them in less long if you find out what's actually going on. and you manage their anxiety, and you kind of divert them to the right places to actually manage their situations. I mean, there is evidence that, particularly in recurrent abdominal pain, that managing their psychological management of their underlying psychological distress reduces reattendance. Just to take one example, so as an individual, it is an investment of time, but I would argue that it is an investment of time that is worth it for the system as a whole. Although, as an emergency department doctor, it's hard for you to make that argument at 2 a.m. on a Sunday. So I get, it's not easy, but I would just make those points.
I suppose just with that specific case, like colic, and more generally, those parents, are sleep deprived and so entrenched with kind of what's going on at the moment. Sometimes I think just asking those questions, do you think might at least open their eyes to the fact that there are multiple issues going on that can be adding into this, and then that they might be able to just knowing that they exist means they might be able to do something about them.
I think that's right, and it depends on the parents, but go on.
Yeah, and I was just going to say, parents are a massive protective factor for these children as well. Yeah, and I think, so I'm a person who's interested in neonatology, and I'm just thinking, is there a way, do you think, that I can, well, not the royal eye, could bring this into neonatal follow-up? Because obviously these babies are going home, and usually these are high risk of neglect, these patients anyway, and often it's the preterms that end up coming to the community paediatricians.
Sure.
So is there a way that this can be adapted to that?
Well, you can just use it. I mean, I think you don't have to write out a grid every time you do it, but you can have in your mind that, if you have, for instance, a particular problem that the family is having, that the mother's mental health and the housing situation and the nature of the relationship with the partner are all valid things to think about when you're thinking, for instance, I don't know, I thought of a feeding problem, because that's a very common post neonatal unit problem, isn't it? Establishing feeding at home. That you've got to talk about those things rather than just the mechanics of, well, is the baby able to kind of suck whatever it is that they're being put in their mouth. So I think you can adapt it to anything if you want to, if you think it's important enough. So the other point I was going to make was about the diagnoses that we make and how we need to be really humble and honest about what the nature of these diagnoses that we're making. So sometimes we're making a very robust diagnosis made on clear pathological grounds. Cancer is the obvious example. Sometimes we're making diagnoses which are on slightly, on the basis of, well, the groups of children who have these kind of symptoms tend to have a similar approach, a similar response to this kind of management. And that's a very different kind of diagnosis. That is, you're not actually saying anything in those kind of diagnoses. I mean, even chronic constipation is one. What does chronic constipation actually mean? It just means you can't poo. There's lots of different things that might be underlying that. So just to say, and colic is a really good example, is there's a pattern of crying babies that happens at this kind of time of life. Seems to be more common in families that are under stress. It seems to be more common in certain situations to do with the baby. We don't know what's happening. We don't exactly know. We can't tell you the precise nature of what is happening in your baby's tummy or whatever. I strongly suspect it's nothing to do with the tummy, but we don't know what's happening. What we know is this group of children with this group of symptoms tend to respond to this management, but tend to is the key word there. And your baby is unique and different, and there are things about your situation that we might be able to do something about, which isn't just focusing on this alleged pathology that's going on in your child's body. Because again, to go back to abdominal migraine, I'm not saying it doesn't exist. I'm just saying we don't really know what it is. And being very aware of that and sort of shedding the kind of false certainty that we're kind of pressured into having all the time as doctors is really important.
health inequalities is a big thing that you've done with your work previously, and I've heard you speak about it. How does this model fit in with health inequalities?
Well, I think in a way, it just, I think if you're not taking a biopsychosocial approach, you can't really understand the impact of health inequalities on health. It doesn't make any sense otherwise. So to take an example, you can't make sense of the effect of poverty on, levels of mental health, on physical health, on obesity, without thinking about how poverty affects your psychology, how you make decisions, and how you let's talk about obesity, because obesity is a now increasingly a disease of poverty. It is under control on most of the population. It is reducing in the more well-off sectors of the population. So this idea that we have an obesity epidemic is actually misleading, because it's in fact the groups where obesity is increasing is just the low-income families. So it is a disease of poverty. So the reason you can't understand why it's a disease of poverty unless you understand why poverty has those effects, why poverty reduces your motivation to have a good diet, why it reduces your access to exercise, why all of these things happen, but also how poverty traps you into helplessness, and how the experience of low paid work, 0 hours contracts, disrupts your ability to run a family, to cook the sorts of meals you would like to be able to cook. So I think it's essential to have a model like this in order to understand why inequalities are important. And I think on an individual basis, I don't necessarily ask people for their income levels when I'm taking history, but I will ask them, where do they live, how many people are there, and does the child have their own bedroom? So sleep, for example, is another example where you need to know all of those things. And if you're in obesity, if you're in an obesity clinic, you can't even get started unless you know what the context is, what the situation is, where they go to school, what their access to exercise is like, are the streets safe. You can't talk about any of these things in any meaningful way other than you should eat less and exercise more, which everybody knows. If you're going to say something that's actually useful, you've got to know the context. You've got to know what's actually going on for the family. So, I don't understand in any of these kind of situations how you could go forward without at least having some of this stuff in your locker.
So with that obesity example, if you're looking at the kind of protective factors, would you be kind of asking the questions, why isn't the child more obese than they are
that's
now?
exactly
what kind of
asking.
things?
Yes.
Yeah.
And that's a really good example. So why have we, let's say, for example, the child has had some kind of intervention for obesity, some kind of, community workshop thing, and it has stopped their BMI going up. Okay, fine, good, excellent. They're still obese, they're still not controlled, but their BMI is still going up, but it's stopped accelerating, if you see what I mean. It's no longer exponential. Okay, good. Why has that happened? What is it that's happened about that? Do they get out? When do they get out? When do they exercise? What, has the family recently managed to get the money together to buy a dining room table so they're actually eating together? Great. So what's the, how is that happening, and what and how can you push that on? Has mum lost a bit of weight? Is she now engaging with dietary advice and kind of gone to Weight Watchers or whatever? Great. Let's move with that. So you're absolutely right. We must not forget, because otherwise we just get so depressed. The reason why taking biopsychosocial approach is not depressing and helpless is because of that final row, the protective factors. What's great about this kid and this family? Because there's always something.
So how do you explain the model to parents?
I think it kind of comes naturally, really. I think if somebody comes, I suppose it's difficult for me to answer that question because it's so ingrained. I'm like, I don't even explain it. I just, it's just there. But I think what I do when I'm talking to, so I just explain how I do it in my practice, and I think there may be kind of useful things to to take to acute practice, and please, sort of tell me if there isn't. I tend to start with the child and talking to them about their life. I don't necessarily talk about their symptoms or their problems first. I talk about their life, what they like, what they don't like, what annoys them. And actually, that's just really helpful in saying, okay, well, this is your life. And then you go, well, how does this problem that you've come to see me fit into that? How does that kind of affect you? And just by making all of the discussion of symptoms about the effect on the child's life, inevitably it comes in. It just can't not. So if I've got a child who may have autism, and I'm talking about, what they like at school, and they talk about the fact that they get bullied, well, we're already talking about that. And so we're already in a biopsychosocial place. We're not in a kind of, counting off the symptoms kind of place. So I think that's one thing, and I think you can do that a little bit in acute, because you can just start not from what seems to be the problem, but tell me about your life. And I suppose that's a very simple thing. If people want a simple kind of take home, which they probably do, that's the starting point, and therefore you don't then have to go, well, now I'm going to do a biopsychosocial aspect of this history, because actually, apart from anything else, that just makes it takes a long time. It's just your starting point needs to be slightly different, and then the rest of it will follow.
This might sound silly, but would you ever use the 3x4 boxes things? Do you get that with parents and say, look, these are some amazing things, or is it more of a conversational type thing?
If you're struggling to explain or to communicate to people how complex some of this stuff is, and so, well, isn't this just this? Well, no, because, and you don't have to do it in the box. You can like, right, okay, so let's say we've got the constipation here. The constipation is a good example, isn't it? And I'm skipping around with my examples, but it just gives you the idea that this is pervasive. The constipation, you've got the difficulty pooing. Okay, well, what's relevant? Well, he's scared of the toilets at school, so that's here. Is there anything else he's scared of? Well, I'll write that there. Okay, and then there's the fact that you're struggling with this, and that you get quite frustrated with him, and going to the toilet's become a bit of a battle, hasn't it? It's become a bit of a conflict between you. So, is there anything else that's a conflict between you? Oh, okay, he also won't eat any of the food. Oh, okay, well, you've been trying to give him a better diet because he needs fiber, doesn't he? And he needs to drink, but he's resisting that, isn't he? What else is he resisting? Oh, okay, he's got the sort of general pattern of oppositional behavior, and he kind of won't go to sleep either, and he's really just generally angry at you all the time. Why do you think he's angry at you? Oh, okay, because you were beaten by his father when he was 3, and you've never really felt since then that you were a good parent, and by then they might be crying, but it doesn't. You can draw all this out. It doesn't have to be in a grid. You can just put it on a bit of A4 blank paper and say, all right, here's the central problem, which is the pooing. What's happening? What are the things that come? What else is also relevant here? Just start drawing arrows and stuff. Won't look as neat as the table. It doesn't need to, because what you've done is just basically come out of the central problem in the middle and looked at the rest of the stuff that's happening around it.
That's super. That's a good kind of practical example. What do you think are some like first steps that people, for someone who's, as you say, most people are doing this to a degree and understand that there are other things going on than what always meets the eye, but to take some practical first steps to make sure that you're doing the best thing for your patients. What are some tips? You've got the grid itself and thinking about those aspects. Are there any other kind of real core things that we should just focus on?
I think that talking about this stuff as teams is quite important. As in, we need to kind of decide whether we're interested in this stuff or not. And because what often happens is that there's a couple of people who are interested in this stuff and they end up doing it all, whereas other people just sort of say, oh, he's interested in that, he'll do that, or she'll do that. And actually, sort of as a team, it's quite helpful to sort of say, well, it's not that we're trying to introduce a kind of audit tool or something. We just need all to kind of agree that this stuff is important and and that we're going to embrace this. I think that local schools of paediatrics are really important here. And I think one of the things that we've never quite got round to as a college is to support schools of paediatrics in running regular joint things with paediatric psychology or joint things with CAMS around the psychosocial aspects of medicine. I think everyone does it to an extent, or I mean, some schools of paediatrics are I keep calling them deaneries, but I'm not sure they strictly are anymore. Some have got a really good record here, but some we don't. Some don't, and we simply don't know who is delivering this and who isn't. If you're a community, I'm going to do a little plug. If you're a community paediatrician, I do run an annual course for incorporating emotional behavioural aspects into community peds, and we are looking at reviving the previous courses for acute paediatricians who want to look more into sort of the mental health aspects. But this isn't mental health as such. This is, everything. This is anything that's not the kind of biomedical stuff. This is much more fundamental. So I think the first steps are to maybe dig out a few, and I can provide some links to papers that we might have written in the past about how to kind of incorporate this stuff. And maybe pick a particular symptom or presentation that you find useful, that you find interesting, and just have a little think about what the psychosocial aspects of it might be. So, for instance, if you're a neonatologist and you're thinking of the post-neonatal feeding problems, or if you're a gastro person, think about recurrent abdominal pain. If you're an emergency person, think about, well, actually, the kids in crisis who come in, how can I approach these in a slightly different way? All of these symptoms, so connected to your own interests, but all of these presentations can benefit from a little bit of a broader perspective.
And you've touched on it briefly, but have you got any more? Can you signpost us to any more resources that trainees can use so we can try and engrave this in our day-to-day practice now?
Yes, there are things. I will have a look, and I will see. I mean, most of my work recently has been more on behavioural difficulties and neurodevelopmental conditions. So I've got quite a lot of writing I can post you to about those issues, which are my core business day to day. And since I don't feel qualified to talk about acute paediatrics anymore, that I've sort of stopped talking about it. But if I look at the college compass and the kind of college learning environment, there will be resources there that you'll be able to kind of plug into in terms of understanding the kind of broader approach. But I think you're right. It's I think one of the things that just occurred to me talking to you is that there isn't a single article or webinar on taking a biopsychosocial approach in paediatrics, and perhaps there ought to be. So maybe this is it. So this is a start anyway.
Have you got any key take-home messages for us, Max? Anything that we can finish with? So on a positive note, that we can think, right, this is moving forward. What can I do as an individual?
I think thinking about psychosocial aspects is not about being a psychologist or getting lost in theory. It's about practical problem solving for this child in this situation. If you start from a slightly different starting point, i.e., tell me about your life, not tell me about your symptoms, it very quickly, very organically will be incorporated into your practice. And you may need to seek the support of your colleagues in doing it, in kind of exploring some of this stuff. But it is ultimately going to make you a better doctor, I think, and more able to help your patients and make medicine in the long term more satisfying for you. So those are my take-homes.
There's nothing to lose anyway, is there? What's there to lose from trying different approaches? And I definitely have found myself, like you're saying, in emergency and speaking to these children and families in crisis, if you start with just, because sometimes they're slightly disengaged, and if you start with, so tell me about what school you go to, tell me about your, it just is a foot in to then actually have some meaningful conversations rather than just, are you suicidal? Can I send you home? It's actually, you're not going to get the answers that you want or that you need. They're not going to be honest, truthful answers. And it's just, it is quite, I think it is more emotionally straining because you get into some of these deep problems that are going in with families. And when you're taking you've hurt your foot, there it's in a plaster, then you kind of not even, engaging your brain about what actually why might this family have more likely to be having a sprained ankle or this behavior that they're having. So everything probably has, an aspect of going into these things. But yeah, I do find that after you come out of a consultation where you have gone into a lot of detail, when you start to realize about the inequalities, and it's quite draining. I don't know, almost saddening sometimes.
I think that's really true, and actually, I think maybe more than the time and this training and everything else, the emotional it makes pediatrics and medicine a more emotionally taxing profession. It makes it, I think, more satisfying to be in, and I wouldn't kind of go back, but it does. And I think one of the problems that we have is we've gone from a profession that basically does a biomedical model to one that is forced partly by circumstance and partly by us acknowledging that these things are out there, to a more psychosocial model, inevitably. But we don't have the backup for ourselves, the supervision that, psychologists will get supervision on a weekly basis to kind of talk through their own feelings about their work. And we don't have that. We're behind on backing ourselves and supporting ourselves to do the emotionally demanding work of pediatrics, and we're not there yet. I think we're getting better. We're certainly getting better than when I was training. It was awful, but I think that's a really good point, that the emotional labour of this, which is genuine, we're not ready for as a profession, and we need to. Particularly, I think there's been more of a focus on colleague and our own well-being during pandemic, and I think one of the key things is to continue that over time, and I just hope we can.
Giving ourselves protective factors.
Yeah, exactly.
Oh, thank you so much. That was so interesting.
No problem at all.
Yeah, I feel privileged to have listened to it firsthand.
Yeah, it's really good and really important, I think. Thanks so much for talking.
Could I put a small plug in for something that I've started doing that might be of interest to people? So there is one other thing that I think paediatricians might be interested in that I'm up to at the moment, which is I've just started with my daughter a podcast for the stories of neurodiverse people and neurodivergent people, so people with ASD, ADHD, dyspraxia, dyslexia, whatever they identify as having. And I think might be quite useful for paediatricians, particularly those who work with those groups, but I think because everyone comes across these people, just to understand them and understand the different ways that brains can come out and how people's brains working in different ways has such an effect on how they interact with things and how they interact with other people. So it might be useful for people to search Extraordinary Brains on whatever podcast provider they have. We are slightly struggling with Apple Podcasts at the moment, but it will eventually emerge into the light of day once they've managed to sort themselves out. So if people are interested, that's something that I'm starting up and feel very passionate about at the moment.
And I just wanted to say thank you again to Max Davie for taking time out of his busy schedule to record that with us. I certainly learnt a lot about the biopsychosocial model, and will probably be starting a lot more of my consultations slightly differently now. And just a reminder to you all to go and have a listen to his podcast, Extraordinary Brains. We'll put a link to it up on our Twitter feed and on our website for you all. Anyway, that's all for this week. Thank you for listening to Dragon Bytes.